All right, hello everybody. Kind of strange having to continue to do these virtually, but we're going to talk today about process improvement and quality assurance with your EMS agencies. It's become a topic now that it's one of the contract deliverables, so you guys need to be sure and be aware of that and review it in your contract. So let's get started. I have no disclosures. Nobody's paying me to be up here to do this, so no disclosures to claim. And what we want to look at and talk about today, and we're going to look at and discuss the need for process improvement and collaboration with your EMS agencies. Some of the things that always come up when we start talking about PA and quality assurance are the HIPAA concerns involved with that. We want to talk about how it does improve the accountability of your EMS agencies when these meetings are going on and you're evaluating their runs, their calls, their cases, and that sort of thing. Community education and how to involve them with those events. We'll talk about training together. We'll talk about some of the things we've done that's been really successful across the state, including the drills that we're doing, and then your PI and QA meetings, and then how this does end up improving patient care. One thing, first point to remember, everybody always asks, does this violate HIPAA if I share this information with my EMS agencies? This has always been an excuse between hospitals and EMS agencies, and hospitals not wanting to share information back to their local EMS providers. They've always claimed, well, I can't share that information. That's a HIPAA violation. Y'all, that is not a HIPAA violation. Anybody that's involved in that patient's care not only should get, but actually deserves to get feedback from the agency or from the site where that patient was transported. Process improvement and quality assurance does not fall under the HIPAA umbrella. If you're meeting behind closed doors and you have a roster with that HIPAA statement at the top and everybody signs that, then that does not violate HIPAA at your facility. EMS needs to be included in those meetings. So I actually, for my sites and you guys that are out there that are part of my groups that I take care of through our program know that whenever we do site visits and we talk about process improvement and quality assurance, I want to see the rosters for those meetings to make sure there is an EMS agency representative on that roster, because we want to know that you're providing that information back to those medics or the supervisors or whoever the PI person is at that ambulance service that works with you, because how else can they improve? How do they know if what they did was good, bad, or otherwise? So we've got to have these meetings to share that information back and forth between the agencies. Do not be worried about it being a HIPAA violation, because it is not a HIPAA violation. Like I said, process improvement improves the accountability. Even things like scene times. If they have a long scene time, that needs to be brought up in your PI meeting so that everybody is involved and everybody knows what may need to be done, change things, and improve those scene times. The pre-hospital notification of a code stroke. Y'all may not realize, but you know why on your calls and your mocks, why they asked that question at the beginning? Was this an EMS arrival and did they notify you of a code stroke? We actually track that data. We want to know that those EMS agencies are doing that for you so that you are able to prepare and get ready for that arriving patient. So that should be part of your process improvement procedures at your hospital. Same thing with the direct to CT. Are they going direct to CT? If they are not, why not? Is it a problem within the site? Is it a particular doctor? Is it a particular charge nurse? Is it a particular medic? All those things need to be looked at, and if it involves EMS, that needs to be brought to their attention about why are you not taking these patients directly to the CT scan. So those are some things to include in those meetings as well. The actual pre-hospital exam and treatment, those are things to include in your PI discussions. Did they follow their own protocols? Did they follow the protocols through our system as far as going straight to CT and those sort of things, and using the terminology to alert you with that code stroke? So all those things need to be looked at and evaluated at those meetings. And then are they leaving documentation in the emergency department after the run? A lot of ambulance services, and I was guilty of it too when I worked as a medic on a truck, I'd always want to go back to the station and finish my run report and fax it over later. Y'all, that can't be done. It's actually in the EMS rules and regulations. These EMS providers have to leave something at the point of patient drop-off. So if your EMS agencies are not doing that, Greg Brown at the Department of EMS has told hospitals he wants to know about it. because they have to leave something. It may not be a completed report, it may be a short form, and a lot of hospitals keep those printed off. They're free, there for the medics to use, but they need to leave something at the point of patient drop-off so that you have information. If they're transferred out emergently to another hospital, then hospital number 2 at least has some scene information as far as initial BFAST exam, Glasgow Coma Scale, vital signs, whatever applies. That has to be left at the point of patient drop-off. So make sure they're doing that, and that would be another thing to include in your topics during your PI meetings at your hospitals. EMS can also be a great resource for your community outreach. Have the ambulance on display at some of these events. A lot of hospitals have done this. I've been to those events. Think about it. It's free advertisement for the EMS agency. They've got their rig all cleaned up and parked there. They give tours of it to the kids. They can give them BFAST magnets, ink pens, whatever kind of swag you want to use. Let them work those events with you. It can do nothing but help your relationship with your EMS. They get to have the ambulance parked there to do that event. And people love it. People love walking up and looking inside those ambulances and touring through, and it surprises many of them, what's involved in an ambulance ride compared to what it was 20 or 30 years ago. So have those ambulances on display at your event. Sporting events, those type of things are great places to use those for your outreach when you're doing your active events. Training together. This is something that we really encourage. This is also a contract deliverable. Not only is doing the process improvement a deliverable, but providing stroke education to your EMS agencies is also a contract deliverable as of a couple of years ago. So if you're holding a class in your hospital or your emergency department regarding strokes for your nurses, why would you not send an invitation to your EMS agencies? Why would they not be invited to come to that class? They need to be getting the same information that you're training your ER staff with, so make sure that they're getting an invitation for that. If you're needing them to have the EMS class that we teach through our office, feel free to contact me. I can come and teach the class at your location. All you have to do is provide the classroom, and I'll come teach the class. You're the organizer. You get credit for it for your EMS education event for that year. So don't hesitate to call me, and I'll be more than happy to come teach that class. When we have our annual conference, you guys get tickets to that. We can provide you more tickets if you need them, but we want you inviting your EMS agencies. We want them to come to the conferences, so give them one of your tickets. Or if you got 2 or 3 medics that want to come, give them some tickets so they have the opportunity to come to the conference and learn and get the same information regarding stroke care that you're doing. Like I said, if you're having any in-house classes, in-services, that sort of thing, they need to be included, so please be sure to invite them. Another thing we've been doing that's really fun is drills with the EMS. We've done a few of these in the last few months, and if you want to get one of these set up, get with me and we'll do this. And what we do on these is we'll have a fake patient in the back of an ambulance, and what we'll do is we'll meet with the ambulance service. I'll meet with them. We'll meet with them, 2 or 3 blocks away. We'll get the patient with the fake IV taped down, teach them how to fake some signs and symptoms of a stroke, and nobody in the ER will know anything about this arriving patient. They don't know it's a drill. And then the ambulance will call in a code stroke over the radio or phone or however they notify the ER, and we'll get to the hospital, and the only person that knows ahead of time is we'll wait just a few minutes before the actual drill, and we'll let the CT tech know so that they don't radiate somebody when they slide them into the scanner in and out, and we'll do these drills. So they arrive, they've called in a code stroke, and if that CT table is available, we'll test and watch and see, do they actually go straight to the scanner? We've had some great successes with this. There was one time we did this with one group. It was great. I'll tell you who they are. It was Stuttgart. We did this class up there, did a drill with them, and it was great, a lot of fun. I dressed up. I had our sim center put a fake mustache on me, had a baseball cap on and some sunglasses, and I wore a T-shirt from the ambulance service, but I had a big name tag that said EMT student. So that allowed me to be the 3rd rider in the ambulance, and it helped me not be recognized by the ED staff. And so I rode in as a 3rd rider. We got there, we called in a code stroke, we got to the hospital, and they sent us directly to the CT scanner as soon as we unloaded the ambulance stretcher. We went to the CT scan. The nurse followed us down with the stretcher like they're supposed to. And while we were doing the drill, they were getting them on the CT table, and the nurse turned her back long enough for me to step up to the CT tech and say, hey, this is a drill. Don't really radiate them. So we did that, got them off through the CT scanner, went back into the emergency department, got them in there, got them ready to do some more exam in the emergency department. The ER doctor asked the patient 2 or 3 questions and then turned to the camera and said, turned away to the nurse and said, call AR saves. So at that point, I said, okay, we can stop right there. And he looked at me like, who are you? And I took off my name tag and my baseball cap, and he said, I know you. You're that guy from AR Saves. I said, yeah, well, this was a drill, and you guys just passed. Because they did exactly what they were supposed to do, going straight to the scanner, getting them back, not wasting any time, calling the call center, and getting that patient ready for a telemedicine consult. And we can do those drills with you guys to test your ERs, and it's just a lot of fun. So if you want to do anything like that, please feel free to contact us and we'll get that set up with you. We just have to make sure that it's a secret and nobody knows about it, but maybe you as the ER director or facilitator and the CT tech, but nobody else should know. And it's a lot of fun. So if you need those, we can sure do that. All right, so including them in the PI process, again, early notification by EMS using a code stroke, protocols for patient arrival, directly to CT, pre-hospital patient care, patients, the course of treatment that you do, opportunities for improvement either by the ED, EMS, or both, and then give the accolades for those jobs that are well done. Don't forget to do that. Patient outcomes, those can be affected because if you're improving the relationship with you and your agencies, all this stuff is falling into place like it should, then you're going to do nothing but improve patient care. And then as a process of doing this, just like with any other PI or QA process, it helps close the loop on these. So these are the things you need to be looking at when you're considering PI with your EMS. This shows that when EMS is involved in the stroke process and doing everything that they should be doing, especially the calling in of a code stroke, we are saving about 12 minutes per patient. Y'all, that's a lot of brain cells. So we've had enough time to gather enough data to prove this, that we're saving 12 minutes per patient when everybody is working together as a team to take care of them. We actually have, as far as giving the feedback to EMS, there's already templates on our website. Don't reinvent the wheel. There are templates on our website that you as the nurse facilitator can go on and use those. All you have to do if you want to is put your hospital logo on the top. However you want to edit those, you can certainly do that, but that gives you a format and a template to use to be able to conduct these meetings and then to be able to give that feedback to your EMS folks. So don't forget the resources that are already out there and available. Make sure that you consider those when you're working with them. If you guys ever want to do anything with your EMS, want me to come teach a class, do a drill, or any of that sort of thing, this is my contact information. My email works best. It comes straight to my phone. Please don't hesitate to call me, and we can set those things up for you. Does anybody have any questions at all?